Thank you. Unlike most speakers that have preceded me, I would like to protest that I do not like the opportunity to be here because I really didn't want to be. I'm replacing a friend of ours who's not been able to show up, but it's been exciting. So here we go. I think basically what I just wanted to highlight as a community person, sorry, I do not have a presentation, I was only told just during break this morning, is this whole issue of mixed messaging that we have received over the years as a community. That has completely confused us, and I think just my colleagues at the table speaking, if I may call you colleagues, speaking earlier on, would probably add a little bit to that confusion, because in one sense, I get a negative message about the impact of early initiation of art, and in another sense, I get a positive message about early initiation of art. And so we are placed in that place where we really sometimes don't know what to do. And so the first step that we want to see is a very clear understanding and some kind of consensus that is beginning to build up, and I'm sure it's beginning to build up through this process, is which is going to be the effective way forward that will have the most positive outcomes for us as patients. Because in one sense, I'm sitting, having started treatment in the early 2000s, I was told, oh, you're starting early, treatment. This stuff is toxic, be careful. It could damage your liver, it could damage your kidneys, it could do this. Your body fat is going to be redistributed and so on. And so after 2 or 3 years of treatment, I read somewhere about treatment holidays. I went back to my physician and I said, doctor, I think I am due for a treatment holiday to reduce the toxicities, flush out toxicities in my body. And, of course, as it turns out, that was probably slightly misguided. But the point I'm trying to drive home is, could you, as our experts, as our carers, as our scientists, as our researchers, just clarify these messages for us so that when we go back to the community, we can confidently say, hey, listen, this is the way forward. And having said that, I just want to also bring this point home that one of the wonderful messages I'm beginning to sort of suss out, if I may use that word, from this meeting is that I am not seeing a lot of negative impact on early initiation. So that is beginning to comfort me a little bit more, because what I keep reading and hearing about is the impact of the results from the HPTN 52. And some of the preliminary data that they came out with, which were good and were positive. What I'm hearing about is some of the observational studies and some of the cohort studies, all showing really good positive data. So that is really a good starting point for me to go back and say, right, if we're going to speak about treatment for prevention, what I do know is that I did not hear any really contradictory data to the extent that it will do a lot more harm than, be able to improve your health as a person who chooses to start ARVs early, if it were offered. And so in that sort of, with that sort of kind of maybe simplistic background, with, after all the confusion with the modeling, some of it I didn't even understand, I just want to just give you my kind of simplistic understanding of what I think is critical for my own health and that I can communicate to the communities when I go back. And so please simplify these messages for us. And please begin to undo some of those negative messaging that has been building up over the years. And we've now got confusion where in one sense we're speaking about treatment optimization, for instance, and in some countries they're still, as a community and as health providers, we agreed we need to take people off D4T. But I was shocked to see that in Malawi, in fact, nearly 100% of patients receiving ART are still receiving D4T. And I'm wondering, goodness, do I really want to initiate and promote early initiation of treatment for people to start with D4T? Those are frightening prospects. And I think the other important point is that even if we do agree that, yes, let's go for early initiation, the patient must still make that final choice. That choice and power to make that choice must remain with me and never with the physician or a healthcare provider. And I think one of the exciting things I keep hearing is that, I think somebody used this phrase that, treatment, it's treatment for treatment, or it's treatment and treatment. And really treatment as prevention is a collateral, outcome. So we are not even really, maybe shouldn't even be talking about as treatment as prevention, but should be talking about treatment and agreeing as to when people should be able to initiate on that treatment. And I am definitely, warming up, apart from the discordant couples, that everybody who wants to start early treatment, I would definitely advocate that they were even, given that option to do so, even in our countries. And I think we should feel a little bit ashamed that the options that we heard are available in San Francisco. Yes, it's a first world country. It's, you got all the financial resources, but we should feel, a little ashamed that that choice and that option is not available to a poor woman in Africa. So it to me is, that kind of disparity should be in itself a basis to be able to drive some of the things that we need to begin to undo and some of the things we need to do moving on forward. And lastly, I just wanted to also just quickly highlight the issue of capacities for the healthcare system to be able to tackle some of these issues we're talking about. And I have a poster outside there, which I'm advertising. And it's really talking about the role that the community can play in taking off this very big load from the healthcare system. And sometimes I think it's exaggerated. For instance, in Zambia, at the treatment center that I go to, the day before I came here, I passed through to promote a bride that they were trying to have to raise some funds. And this was at 14:30 or 2:30 in the afternoon. And the counselors were sitting, they had no patients. The doctors and the clinicians were sitting, they had no patients. And I said, how come? It looks empty. He says, all the patients came by 11 o'clock, we were done. And so we're just waiting to go home at 4:30. So in some instances, it isn't as bad as we assume it is everywhere. In some instances, there is some capacity within the current health systems to absorb even the expected high volumes, which I don't even anticipate in any case. But even if the health system was overwhelmed, that the community is there to support this, and the task shifting process must begin to take place. And this is where WHO leadership is going to be critical in convincing some of our governments that is good HIV care that should be adopted by them. Lastly, I just wanted to I think I'll finish there. I think that's all I wanted to say. Thank you very much for listening to me.